All right, welcome to our OCS Masterclass. If you're prepping for the board exam or you're just looking to get sharper in the clinic, you are in exactly the right place. Today, we're taking a deep dive into 3 super high-yield hip and thigh conditions. And my goal here is to go way beyond just a simple review. I want to arm you with the kind of evidence-based mastery you need to walk into the clinic on Monday morning and just nail it.
So here's our game plan. We're going to start by setting the stage, framing the clinical challenge. Then we're going to break down the evidence for adductor strains, hamstring injuries, and greater trochanteric pain syndrome. And we'll wrap it all up by putting that knowledge to the test with a case study to make sure the biggest points really stick.
Okay, so let's set the stage here. These injuries are incredibly common. But the fact that they come back over and over again, that's a huge red flag that what we're commonly doing in the clinic just isn't cutting it. Our job today is to close that gap between what the evidence says and what we actually do. I mean, picture this scenario. You've all seen it, right? An athlete feels that pop in their groin. They rest for a few weeks, do some basic stretches, and then they go right back to playing, only to pull it again a month later. It's a frustrating cycle. But the evidence we're about to dig into shows it's totally preventable. It just takes a much smarter, more active approach.
And here's my promise to you. By the end of this explainer, these are the skills you're going to have. We're not just memorizing facts for the exam. This is about building a deep understanding of the why behind what we do so you can make better clinical decisions, get better outcomes, and of course, crush your OCS exam.
All right, let's kick things off with our first deep dive, adductor strains. Think about your soccer players, your hockey players, anyone who needs to cut, kick, and explode. These injuries are a massive headache for them. And as we're about to see, just telling them to rest is pretty much the worst advice you can give. So here's the absolute key concept. It's not about how strong the adductors are in isolation. It's all about the balance of power across the hip. The adductors and abductors are in a constant tug of war to keep the pelvis stable. And when that tug of war is lopsided, the adductors are the ones that are going to pay the price. Now, the research gives us a very specific, a very objective number to watch out for. If an athlete's adductor strength drops below 80% of their abductor strength, they cross a major red line for injury risk. And you won't believe how much that risk skyrockets. Let that number sink in for a second. 17 times. That's not a typo. A landmark study by Tyler and his team found that an athlete with that weak ratio is 17 times more likely to get an adductor strain. This is one of those stats you just have to know cold, for the exam, for your screenings, for everything. So how do we fix it? Well, the rehab is a clear step-by-step progression. We start with protection, gentle movement, pain-free isometrics. Then we start to build things back up, moving from isometrics to concentric, and then, most importantly, to eccentric loading. But here's a quick clinical pearl. You'll notice soft tissue work on there. The evidence for it as a standalone treatment is actually pretty weak, so think of it as a helpful add-on, but your real moneymaker is going to be that progressive, active loading. And speaking of loading, you need to know this exercise. The Copenhagen adductor exercise is an absolute game changer. It's a tough, eccentric-focused exercise that directly attacks the mechanism of injury. We know from research that just adding this one exercise can significantly boost eccentric adductor strength. It is an essential tool for your toolbox, especially in those later stages of rehab. Okay, let's switch gears and talk about the dreaded hamstring strain. These things are notorious for coming back again and again. But the key to finally breaking that re-injury cycle is using a structured protocol where we advance the athlete based on meeting clear criteria, not just by looking at the calendar.
We can break the whole process down into 3 clean phases: acute, intermediate, and late. First, we protect. Then, we rebuild the foundation. Then, we get them ready for their sport. But here is the most critical principle, and I really can't say this enough. You only move to the next phase when the athlete proves they're ready by hitting objective goals. We'll look at those right now.
This table right here, this is your clinical cheat sheet. It's straight out of the orthopedic monograph. Now, I want you to focus on that last column, criteria for advancement. To get out of that intermediate phase and into the late return to sport phase, look at this. They need symmetrical flexibility and, listen up, greater than 90% strength compared to their other leg. That objective number is what keeps us from sending them back too early and starting the whole cycle over again.
If you remember only one single thing about hamstring rehab, please let it be this. Eccentrics are king. Look at this data. An 85% reduction in recurrent injuries. That is staggering.
This makes exercises like the Nordic hamstring curl a complete non-negotiable in any modern hamstring program. It trains the muscle to handle braking forces, which is exactly when most of these injuries happen.
All right, on to our final topic, greater trochanteric pain syndrome, or GTPS. And this is an area where, honestly, our entire way of thinking has flipped upside down. The old model of it's just bursitis can actually lead us to do things that make our patients even worse. So here's the massive paradigm shift. We now know that GTPS usually isn't an inflammatory itis. It's a compressive tendinopathy. The glute med and min tendons are literally getting squished against the bone. So think about it. What's the worst thing you could do? An aggressive IT band stretch that pulls that hip across the body and squishes those tendons even more. The entire focus now is on managing that compression and building up the strength of those gluteal muscles so they can tolerate load better.
And this is how we put that new model into practice. Honestly, your most powerful treatment is education. Just teaching a patient to stop crossing their legs, to stop hanging on one hip when they stand, or to sleep with a pillow between their knees. These simple changes can dramatically reduce that constant compression. Often, this gives them huge relief before you even start a single exercise.
Okay, we have covered a ton of ground, so now it's time to put it all together. Let's run through a quick case and a few practice questions to really challenge your reasoning and make sure this knowledge is locked in and ready to go. All right, let's meet Sarah. I'm sure this presentation sounds pretty familiar. Take a quick look at her case. Based on what we've talked about, what's your top diagnosis? And more importantly, what are you going to do on day 1? So here's your first question. For Sarah, what is the most appropriate initial intervention? Think about that paradigm shift we just discussed, that move away from stretching and toward managing compression. Get your answer in your head? Okay, hold that thought. We're going to do 2 more quick retrieval questions, and then we'll circle back and break down all the answers. Okay, pop quiz number 1. What's that magic adductor to abductor strength ratio we talked about? The number you have to stay above to keep that injury risk low. Lock in your answer. And for our last question, think back to that hamstring rehab protocol. What's the specific strength percentage an athlete has to hit before you can safely clear them for that late sport-specific phase? All right, let's see how you did. For Sarah's case, the answer is C. You have to start with education and load management first to stop irritating that tendon. For the adductor ratio, the magic number is 80%. And for that hamstring progression, the benchmark is greater than 90% strength symmetry. If you nail those, you are well on your way. These are the details that separate the experts. I know that was a dense, evidence-heavy session, so let's boil it all down. If you're going to remember just 5 things from today for your exam, for your patients tomorrow, make it these 5.
This is your blueprint. Number 1, the 80% rule for adductors. Number 2, for hamstrings, eccentrics are king, non-negotiable. Number 3, use criteria, not the calendar, to progress your rehab. Number 4, for GTPS, think compress, don't stretch. And finally, number 5, for GTPS, your first and best tool is education. If you can burn these 5 principles into your brain, you will be a better clinician.
So I'll leave you with this one final thought. I want you to think about the very next patient who walks into your clinic with a hip or thigh injury. What is the one principle from today that you are going to consciously apply to their care? Make that your mission. Thanks so much for joining me for this explainer.